So hi students, in this video we are going to see about the remaining types of anemia in pregnancy, right? So anemia in pregnancy. Remember, the most common cause of anemia in pregnancy is, yes, physiological anemia. Okay? And which is the most common pathological cause? Yes, very good. It is iron deficiency anemia. Okay? And if you ask me, which is the second most common pathological cause, then it is going to be anemia in chronic disorders, right? So, what are the chronic disorders that are going to cause this anemia? Okay, the most important cause is chronic renal insufficiency. Then it is going to be the connective tissue disorders. Then your granulomatous infections. Inflammatory bowel disease and neoplasms. Okay. Next we will see about megaloblastic anemia in pregnancy. The incidence of megaloblastic anemia is around 0.2 to 5%. Okay, and it can occur either due to folic acid deficiency or vitamin B12 deficiency. So, if there is a deficiency of folic acid or vitamin B12, the DNA replication in RBC is getting affected. That will lead to derangement of red cell maturation. So, abnormal precursors of RBCs are produced, which are known as megaloblast. Okay. Now we will see about folic acid alone. So, if you take folic acid, on reduction it forms dihydrofolic acid, and again it will be forming tetrahydrofolic acid. Okay. So, this is important for the cell growth and division. Then it mostly coexists with vitamin B12 deficiency or iron deficiency also, and deficiency of folic acid causes neural tube defects. Okay. So, what are the causes in which folic acid deficiency occurs? So, the causes include, first cause is dietary deficiency, then prolonged cooking of vegetables, then malabsorption syndromes, okay, like tropical sprue, then when there is multiple pregnancy, okay, it is associated with any hemolytic disorders like sickle cell disease, HIV infection. Then suppose if she is on antifolate medications, okay, like the antiepileptics, okay. And alcohol consumption also. Okay. So, all these things can cause folic acid deficiency. If you take vitamin B12 deficiency, that is cobalamin deficiency. Okay. So, in this most of the women are asymptomatic. And remember, vitamin B12 stores are very large in our body. Okay. So, it takes so much of time for depletion of these stores. Okay. Takes time to deplete them. Okay. And as we have already seen, this is not seen alone, may coexist with iron deficiency or folic acid deficiency. Okay. May coexist. Okay. Now, we will see the causes of vitamin B12 deficiency. Number 1 is due to inadequate intake. Okay. Especially in the vegetarians. Okay. And due to malabsorption syndromes, and due to pernicious anemia. Pernicious anemia is an anemia which is caused due to deficiency of intrinsic factor. Okay. Then, if there is a history of gastrectomy, even in gastritis and also in HIV infection. Clear? Now, what are the clinical symptoms we see in megaloblastic anemia? So, megaloblastic anemia, clinical symptoms. This include glossitis, burning or soreness of tongue, nausea, vomiting, heartburn. Then in vitamin B12, neurological symptoms are also seen. Okay. So, the neurological symptoms include paresthesias, numbness, weakness. Then there can be personality changes also, memory changes, subacute degeneration of the spinal cord, then skeletal changes, even osteoporosis. Okay. Now, we will see what are the effects on pregnancy. They can cause miscarriage or preeclampsia like syndrome, or fetal growth restriction, abruptio placenta. Okay. But the risk of abruptio placenta is not proven, but still we can give the risk. Okay. Now, we will see how the diagnosis is made. Okay. See, diagnosis is usually made on CBC. If we see there is a low hemoglobin content and reduced RBC count, platelet count, and WBC count, if you take, it can be low or normal. Okay. And then we will see the indices. The RBC indices are going to be high. So, MCV is going to be more than 100 picoliters, and MCH is also going to be high. And if you take the peripheral smear, Okay. So, this is one of the important investigation you have to do in anemia. In the peripheral smear, you will be able to see hypersegmented neutrophils. Okay. If you see serum investigations, the serum levels will have, and if you see in the serum, you will have high homocysteine levels, and there will be definitely reduced levels of folic acid as well as reduced level of vitamin B12. Clear? So, this is the peripheral smear picture of macrocytic anemia, okay, or megaloblastic anemia. You are able to see macroovulocytes, okay, you are able to see some teardrop cells and hypersegmented neutrophils also. In contrast, if you take the microcytic hypochromic anemia, that is iron deficiency anemia, you are able to see some pencil shaped RBCs, okay, and microcytic RBCs, okay, microcytic and hypochromic RBCs, and that is a target cells, that is our targeted RBCs are also seen, okay. So, management of folic acid deficiency. First, we will see the prophylaxis, okay. So, prophylactic measures of folic acid deficiency, you have to supplement them with 400 to 500 microgram of folic acid and 4 to 5 milligram of folic acid is given if there is a previous history of neural tube defects. Clear? And then you have to remember that it should be ideally started 1 month before the conception itself, and it should be continued minimum 3 to 6 months after delivery also. Okay. So, for the treatment purpose of folic acid deficiency, you will be supplementing folic acid tablets, okay, that is orally at the dose of 1 to 5 milligram per day, and we know folic acid is going to be supplemented with the iron also, okay. Now, along with this, we can even give ascorbic acid 100 milligram TDS, that will help in increasing the absorption, okay, and it also helps in conversion of folic acid to folinic acid, which will be easily absorbed. Clear? And regarding vitamin B12 deficiency, you have to give IM injection of cobalamin. The dose is 1000 micrograms or 1 milligram, and you have to give weekly injections for 6 weeks, okay, and this should be followed by monthly injections for 4 to 6 months. Clear? Now, we will see about hemoglobinopathies. See, hemoglobinopathies are inherited biochemical disorders. Hemoglobinopathies are the inherited biochemical disorders within the specific polypeptide chains of the globin fraction of the hemoglobin. Clear? See, if we take hemoglobin, you have heme and globin, right? Now, if you take this globin, okay, you have 4 polypeptide chains. You can have 4 polypeptide chains, okay. So, that is alpha chain, beta chain, gamma chain and delta chain, right. So, normal adult hemoglobin has, yes, 2 alpha chains and 2 beta chains. Similarly, fetal hemoglobin has 2 alpha chains and 2 gamma chains. Clear? Okay. Now, we will see what is sickle cell disease. Okay. So, what is going to happen is there is a point mutation on the beta globin gene. Okay. So, there is a point mutation in the beta globin gene, and this gene is present on chromosome 2. Okay. So what happens is G goes, V is welcomed. Okay. That means glutamic acid goes, okay, and it is substituted by valine. Okay, and this will be happening at the 6th position of the beta chain in the globin. Clear? Now if you take, you have two variants in this disease. Okay, they can be SS or SA. Okay, so that means they are homozygous and here they are heterozygous. Okay. So SS means they are prone to get sickle cell anemia, and when they are heterozygous, it is called as sickle cell trait. Okay. Now we will see the specific features of these two things. So that is HBSS homozygous and HBSA, okay, that is heterozygous. Okay. In HBS, 70 to 90% is HBS and 10 to 20% is going to be HBA. Okay. Whereas in HBSA, it is only 10 to 40% of HBS and the remaining 50 to 60% is of HBA. Okay, so which is good? This sector is good, right? Because they are having more normal hemoglobin. Okay, A means adult hemoglobin, right? And next one, the hemoglobin range in the first category, that is sickle cell anemia, will be around 6 to 9 gram per deciliter, whereas here it will be around 13 to 15 gram per deciliter. Okay, and sickle cell anemia patients can have a life expectancy up to 30 years, whereas in sickle cell trait, they can have a normal life expectancy. Okay, so here propensity for sickling of cells is present. Okay, propensity for sickling of cells is present, whereas here that is not seen. Okay, so if you see overall, sickle cell trait is a benign disease. Okay, and most of the times the patient will be asymptomatic only. Okay, whereas sickle cell disease, that is anemia, is not like that. Here the patient is going to be severely symptomatic and going to face all the complications. HBS normally is in the soluble form. Okay, so it doesn't create any problems at all. Okay, when there is a proper supply of oxygen. Okay, that is important. Okay, but when there is deficiency of oxygen due to any reasons, okay, what happens is this HBS polymerizes. Okay, polymerizes and it forms tactoid polymers. Okay, tactoid polymers, and this will cause the RBCs to deform. Okay, now what happens is this deformed RBCs will be seen in the sickle cell shape. Okay, will be seen like this. Okay, sickle shaped RBCs. Clear? So now if you see this peripheral smear, you will be able to identify. So repeat. So if you see this peripheral smear, you will be able to make. Okay, so these are the normal RBCs. Okay, and these are the sickled RBCs. Okay, and remember the sickling also depends upon the pH. Okay, decrease in oxygen, as I have already told, and the dehydration level of the patient. Clear? Now, why we are talking about sickle cell anemia in pregnancy means, we will see the effects of the sickle cell anemia on the mother and the fetus. Okay, on mother and fetus. So, number one, sometimes they can result in miscarriage. Okay, then they can result in gestational hypertension, and the prognosis, like it can result in preeclampsia or eclampsia. Okay, and then it can result in fetal growth restriction, sometimes even in preterm birth, okay, and abruptio placentae, okay, and during labor they can cause fetal distress, okay, and in the mother they will increase the need for cesarean section and postpartum infection and sepsis. There can be chances of renal insufficiency, urinary tract infections, cerebrovascular accidents, then also cardiac dysfunction and leg ulcers. Clear? So, whenever there is a pregnancy coexisting with sickle cell disease, okay, first a pre-pregnancy evaluation is needed, okay. So, pre-pregnancy counseling and evaluation is needed. First, you have to confirm the subtype of the disease, okay. So, first confirm the subtype of the disease. If she is already taking a set of medications for her sickle cell disease, some of the medications has to be stopped before pregnancy, okay. So, stop the medications like hydroxyurea, chelating agents, angiotensin receptor blockers, okay, or angiotensin converting enzyme inhibitors, right. And then you have to give her a genetic counseling, and also importantly you have to give them genetic counseling, okay. So, genetic counseling should be given to both the partners, okay, and if needed for the fetus also you have to do pre-implantation genetic diagnosis or prenatal diagnosis as needed. Clear? And next important step is about vaccination. You have to check her vaccination status on pneumococcus, meningococcus and Haemophilus influenza B, okay, it is Hib B. Clear? And also if needed, early detection and treatment of infections like malaria and other infections, okay, would also help, right. Next one is, we will see what we are going to do with the antenatal care and how we are going to plan her delivery, okay. So, first step, you are not going to administer her iron, okay. So, iron should not be administered. And what is the folic acid dose? Yes, it is 5 milligram, okay. So, folic acid should be given at a dose of 5 milligram, and you have to keep a check on anemia and infections, okay. Routine screening should be taken for all these things, especially the hemoglobin should be maintained above 8 gram per deciliter, okay. And you have to start them on low dose aspirin, okay. So, low dose aspirin should be started from 12 weeks of gestational age, and for thromboprophylaxis also you have to start them with, yes, low molecular weight heparin, okay. Suppose if there is a crisis present, okay, sickle crisis is present, then in case of sickle crisis you have to give fluid therapy and oxygen therapy, and see that the oxygen saturation is maintained above 95%. Clear? Some of the indications of blood transfusions are when it is a multiple pregnancy and there is a state of severe acute anemia. Clear? right? And how we are going to plan delivery? Delivery should be planned ideally at 38 to 40 weeks of gestational age, and you are going to plan a normal delivery only, okay? C-section is indicated only for obstetric indications. Clear? Next we will see about thalassemia in pregnancy. So, thalassemia in pregnancy. Remember, thalassemia is a autosomal recessive condition. Okay, so it is a autosomal recessive condition, and it is the most common single gene disorder in the world. Okay, most common single gene disorder in the world, and this is a type of macrocytic hypochromic anemia. Clear? So, we have two types of thalassemias. Either it can be a beta thalassemia or it can be a alpha thalassemia. So, what is happening in beta thalassemia is the beta chain production are going to reduce. Okay. So, beta chain synthesis are reduced, whereas in alpha thalassemia, alpha chain synthesis are reduced. Okay. And the chromosomal defect in beta thalassemia is seen in chromosome 11, whereas for alpha thalassemia, there is a defect in the gene located on chromosome 16. Okay. Among beta thalassemia and alpha thalassemia is more common, whereas alpha thalassemia is less common. Okay. Again, beta thalassemia is divided into three types, namely beta thalassemia major, intermedia and minor. Okay. Okay. It simply means there is marked reduction of the beta chain synthesis. Okay. Here the level of beta chain synthesis are moderately reduced, and here there is a maximum reduction in the beta chain synthesis. Right. And similarly, alpha thalassemia is also divided into four types. So, there can be a silent carrier type, okay, in which there is only one gene deletion is happening, right. So, if you take alpha means there is only one gene deletion, okay. So, that is single carrier, silent carrier type. And next is alpha thalassemia. Trait means there is two gene deletion, okay. So, two genes are gone, okay. Next is HBH disease, that is three things are gone, right. Next is HB Barth's disease, all the four genes are deleted. Clear? Yes. Now, we will see the clinical features of thalassemia. So, clinical features include pallor, jaundice, there can be splenomegaly, and signs of vaso-occlusive disease. Okay. So, signs of vaso-occlusion, like there can be acute chest syndrome, okay, they will be presenting with pulmonary symptoms, and in the bone there can be dactylitis, and in the brain stroke can occur. Clear? Now, what are the lab investigations will do and what will be the interpretation will make? So, lab investigations. So, there is anemia. So, hemoglobin levels are going to be reduced in your CBC, and then if you take the RBC indices, all the indices are going to be reduced. So, your MCH, MCHC, okay, and even your MCV, okay, all these things are reduced, right. And then peripheral smear, already I told you what kind of anemia you will be able to see in this Yes, it is microcytic hypochromic anemia. Okay. And we will also be able to see target cells. Okay. There can be basophilic stippling. Then Howell-Jolly bodies. Okay. The screening test for thalassemia is Nestrov test. Okay. That is naked eye single tube. So that is naked eye single tube red cell osmotic fragility test. Okay. Clear? Now we will see the obstetric implications. See, the fertility is not impaired in these patients. Okay, fertility is not impaired, and the pregnancy outcomes are also good. Okay, so pregnancy outcomes are good, and then you have to give them proper pre-pregnancy counseling. Okay, here also we have to maintain the hemoglobin levels more than 10 gram per deciliter at least, and remember these people would have been on multiple transfusions since the younger age itself. Okay, so already there will be iron load. Okay, so no iron supplements, only you are going to give them folic acid at 5 milligram dose. Okay, and you have to make sure that they are vaccinated properly, especially against the pneumococcus. Okay, and delivery, we are going to offer them a normal vaginal delivery. Okay, cesarean section is only for obstetric indications. The labor can be managed normally, and breastfeeding is not contraindicated. Clear? So I hope we have completed all the types of anemia in detail. So the most important type of anemia you have to learn completely in and out is iron deficiency anemia, but questions on the rest of the types of anemia can also be asked, right? So until we meet in the next video, take care, happy learning, and bye bye.